So temporal sick, my choice. Superiorly, you see, issues are deep set eye, small or a large orbit. Approach to sight is difficult. Many times we may not be able to have that kind of exposure which is required. If you are making a conjunctival incision, I have seen many patients with the lacerations. I have a referral of keratoplasty, and I see more than 10% of my patients, those who come for the keratoplasty, is the bad small incision keratosurgery, surgery, the incision of the conjunctival lesions. So, laceration, buttonholing, stuck in wound, granuloma formation, retraction, or a bleeding is going to hamper the surgery. Scleral issue, which we seldom see, is tunnel creation. One, buttonholing of the sclera. It would not be able to be managed once it's been buttonholed. Early entry, thickness may be more than 50 or less. Cortex induced inflammation. If the cortex is stuck into this trapezoid kind of incisions, it's going to give you inflammation postoperatively. And bleeding is more with this. You have to cauterize. It will lead on to scarring. Direct and indirect ciliary body insult. We are working very near to the ciliary body. These patients would have uveitis, choroiditis. Issue. The nucleus management is difficult. Maneuverability gets a longer. You have a less space to manage the nucleus. While you see in the temporal, you are directly onto the site. More space, better exposure, easy reach. So these are the few of my videos which I'm going to share with you. So these are just 1 minute, 2 minute videos. I always go with 2.8. Definitely I mark at the limbus. Limbal or slightly pre-limbal is my choice because the conjunctiva there would cover the wound. I enter with 2.8 and extend the incision. Before that I put methyl, visco and rexus forceps is at my help to complete my rexus. The third step is with a blast cannula. We have learned from Dr. Daljit Singh. I use 18 gauge cannula to push out the nucleus. It's you irrigate at one location, it's going to come out of it and it would come whole. Many a time when the nucleus is harder, it's difficult to take. Incision size is never more than 6. It's always 5.5. I insert lens through 5.5 and take out whole material from 5.5. And I use irrigating vectors. So that's going to help me to break the nuclei into pieces in the wound, what we call nucleus dissection. This is a patient with a not fully dilating pupil. The other patient is exfoliation. Exfoliation in the periphery is quite common and we need to be very careful. I would prefer slightly larger capsular access in these patients. So all cataract surgery in small incision, the same steps. Only you just need to change the size of the rexus. I would come to the astigmatism also. We have done a study, not one, we have done 3 studies, wherein we find the astigmatism induced in the temporal was almost half of the superior. If you permit, sir, I should continue 2, 3 more. So aspiration is with the irrigation aspiration. I use indirect Simcoe or Dr. Daljit Singh Kerala as whatever is available. So when you are aspirating, try to hold the anterior part of the cortex and you can peel it off. Try to peel it off. Hold and then you pull it centrally and the things are quite clear. And this is a very interesting situation. These kind of patients, hypermature. You enter the You start the rexus with the keratome itself, because to complete or to start to initiate rexus in this patient with the forceps is difficult. To save your time, enter with the keratome, and then you fashion that rexus to your desired size. And Morgaginian cataracts, hypermature cataracts, compromised zonules is easy to tear with a keratome. Of course, I do stain also, but most of the time I don't stain even. Less of the carbon print I want to. And only 2-3 instruments I use for the small incision cataract surgery. I believe in simple instruments, simpler surgery than complicating your mind or with the instruments, equipment. So it should be, a harder capsule nucleus you can take out in at the most 2 bites. So these fluffy kind of cortex, you can easily wash it off. This is harder cataract. I would go forward. So this is, sorry, this is a real time surgery. You would find approximately 2 minutes or 2.5 minutes. So you have saved time, you have saved carbon prints, you have bypassed many steps, which is cumbersome to learn, to execute. And this surgery is going to help you for your phacoemulsification, which is call of the day and everybody needs to learn. So this is the this month surgeries only, around 2 weeks back. My choice is Rexus forceps if the incision is more than 2.2, or the Haldi Brooker if the incision is 2.2 or 2. Less than 2.8. So choice for removal is always vectus, irrigating vectus. Smaller would come of its own in one go. Harder, you may be a black cataract, you have to, you just punch it, and then you have a crescent kind of a nucleus left behind, which you can just rotate it from the wound. Maybe there was one video which I crossed over because of the scarcity of the time. So aspiration, I believe, is easier in cane opener as compared to Rexus for the beginners. Once they have done around 100 cases of a small incision with the cane opener, they can always shift on to this continuous curvilinear continuous Rexus. So they have built that confidence in them that we can go across without any issues. So this is the day one post-operative. All patients. You see the cornea is clear. I always put a air bubble, which is again a controversial. People, they don't say, but I put it because it's going to give me assurance that there is no visco, there is no rise pressure in the next day. But the bubble has to be monitored that it should not block the pupil. So there should be an excess of the aqueous from the posterior chamber to anterior chamber. So there is not a raised pressure next day, you see, and it's going to give you a good clarity. And about the astigmatism, this is the post-operative astigmatism of these patients. Nobody is more than 1.5. Maybe I have done more than 10,000 or 20,000 cases. I've come across seldom any surprise to see. Thank you.
But 20 years back when I started my SICS revival, the scan openers we started only with the clinic.
Yeah.
Only one thing in back of their mind. When I catch the tag of the canopy, I made it with tremendous confidence.
So in cane opener, you make very small cuts.
Yeah, believe very well
So
when
it's
you
as good as with the femto. And with the small cuts, there would not be ragged margin of the capsule and you would not catch hold of it. The second thing is you just rub the undersurface of the capsule to make that cortex slightly raised from there. Then you hold the rhexis of this cortex, you pull it out. Try to pull the rhexis cortex away from the rhexis. So you would never catch hold of this. Even if you catch hold of this,
That I said that
injected. Yeah.
running block. But this is the fact that you are in a straight, the tag is there,
Yeah.
not colored with anything.
Thank you, sir. Thank you very much for nice videos. So your videos are always excellent, sir.
Thank you.